Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast here at the Pacific Neuroscience Institute in Santa Monica. And today, I am sitting down with the director of PNI and one of the four co-founders, Dr. Daniel Kelly. So, how are you?
I'm good.
Good.
How you doing, Anthony?
I'm pretty well. I'm glad to be back in Santa Monica after a long COVID hiatus.
Yes.
And I'm hoping that it doesn't turn into another one. You've been busy during COVID.
I have.
And you're going to tell us today about some of the papers you've written on your experiences with brain tumors, which are a fundamental part of your work here.
That's exactly right. It's been a team effort with all my colleagues and our fellows, students, and we've really had some remarkable success in getting some really nice papers published, which I'll go into some detail on.
Tell us what's going on.
Well, when I came from UCLA to St. John's, I joined the John Wayne Cancer Institute to really start a brain tumor program, which didn't exist. That was in 2007. And over time, we've built that up. And we have, brought in this amazing team, Dr. Griffiths, Dr. Kraus, two of our founders, Dr. Kesari, neuro-oncology, my partner, Garni Barkadarian, Walavan Sivakumar, one of our former fellows. We've really added faculty into the realm of brain tumor. Dr. Kesari now has 3 other neuro-oncologists. And so really the foundational program of PNI has been around brain tumors. So that includes brain tumors that are in the brain, pituitary tumors, and tumors of the skull base. And some are malignant, some are benign, but it's a big swath of pathology, and we've excelled in that. And one of our main focuses over the years has been minimally invasive approaches and complication avoidance. And we've become known really, around the country and around the world for our expertise in these areas. We do a lot of teaching, we write a lot of papers, and really in the last 2 years, what's been nice and partly, I guess one of the silver linings of the pandemic is that we have been able to really produce some really high impact publications on our experience in brain tumors across the full spectrum, from things such as meningiomas to pituitary tumors, and everything, all the other sort
Meningioma,
of
what's that?
So meningiomas are the most common primary brain tumor. They arise from the meninges, the coverings of the brain and the spinal cord, and they tend to be more common in women. They're generally benign. 85 to 90% are benign, meaning they're not cancerous, but they tend to get wrapped around things. They can get very stuck to the brain. They can get wrapped around cranial nerves and blood vessels. And we spend a lot of time taking them out. We do a lot of meningiomas through the nose, actually, and we do other keyhole approaches. And one of the things that PNI is known for is keyhole neurosurgery for brain tumors. And so we've had some really nice papers come out. I'll just run through a few that have just come out. In the last year or so, and this is a collaboration with all of my colleagues and our fellows, and some of our students. So it's not only are we doing good clinical work, but we're doing this academic work. We're training people. This is part of what PNI is all about. The research and education that we do. So if we go back to 2020. We published 2 papers, one on meningiomas in the elderly and one on pituitary tumors in the elderly. So people, and we call elderly 65 and over. Which I'm pretty close to. So I don't like that. I don't like that term, but really good outcomes. This was in two different journals on our short length of stay, low complications, and the fact that you can operate on people who are 65, 75, 85. With good selection processes, and that patients
good
can
selection
do well.
processes.
Meaning,
what does that mean?
Meaning that we don't operate on everyone,
right?
And in these 2 papers, one of the important points in both of these papers is we looked at over the same time period of what percent of patients that we saw in our clinic that we didn't operate on. And for the meningiomas, it was almost a third. So that we would see someone who's 70 years old, who's diagnosed with a tumor. Maybe they had a headache, maybe they fell down, they got a scan, they had a small tumor, not symptomatic. We don't operate on that patient. So a third of the patients with meningiomas that we saw in our clinic, we didn't operate on. We just watched them. We do say, come back in 6 months, we're going to do another scan.
Okay.
In the pituitary adenoma paper, it was about 25%. So similar numbers,
that you determined could do just fine without surgery.
Yeah, that these were
Okay.
incidental findings. They weren't symptomatic. And I think that's a really important part of those papers. Not only that when you do the surgery, you can do it safely and you get people out of the hospital quickly, but that, there's a lot of people who, in fact, don't even need surgery, and you can walk away. And we do see people that out there that get operations that probably they didn't need an operation, So I think this watch and wait approach is an important concept of, the judgment of surgical judgment. And
certainly. Well, that reminds me of prostate cancer, and that watchful waiting became an option in the last decade or so. And, arguably it saved a lot of, wear and tear and bad outcomes.
Exactly.
Okay.
So those were two papers. And then...
did you focus on the elderly there because these tumors are more common in the elderly? Or why did you pick that population?
Well, in fact, it was... there was a request for papers. Sometimes the journals will say, we're going to do an article, we're going to do an issue devoted to surgery in the elderly. And so, they actually asked for manuscripts. And not all of them, they all go through a peer review process. So that was, and we submitted 2 to the same journal. They took 1, and the pituitary one they didn't take, and probably because they just said, we can't take 2 from the same institution.
You can't own the whole journal.
Yeah. So then we triaged that one to another journal. So that was those 2. Then we had a couple articles. We've had 3 articles that are looking at keyhole approaches. So
you describe that. Describe keyhole, because I think everybody needs to hear that again.
Yeah. So the keyhole is the concept of a minimally invasive approach, doing an approach to a brain tumor through a smaller approach than a conventional, traditional, larger craniotomy.
Like we're talking about taking off a big piece of the skull to get at the brain.
And in these papers, we define it as an alternative approach to a more conventional approach that is well published in the literature. It's a significantly bigger approach. So, for example, one keyhole route is through the nose, okay, as opposed to doing a craniotomy and taking out. So there's a lot of midline brain tumors. Virtually all pituitary adenomas we take out through the nose.
Because of the placement.
Because where the
pituitary
gland sits right in the midline, behind the eyes, in the base of the skull, and the best approach is essentially through the nostrils into the sphenoid sinus, and you remove a little bone, and you're staring at the pituitary gland.
And this was kind of your, you did this.
Well,
right?
It's been around for. Yeah, I'll get to that. Our paper. We published a paper on 514 patients just recently on our whole pituitary adenoma experience over 12 years or so.
Wow.
That just came 10 years. That just came out. But I'll get to that in a second.
Okay.
So the keyhole approach is the idea is smaller incisions, less muscle manipulation, less bone removal, no retraction of the brain, and less collateral damage. That's what the keyhole concept is about. Okay, it's doing things through smaller, more refined openings, using navigation, using instruments that are very low profile that allow us to get in without and that allow our hands to not be in the way, using the endoscope to bring, a surgical telescope to bring into the field to give us a view that you can't get with the operating microscope. using things like the Doppler probe to make sure we localize blood vessels before we injure them. And then also patient positioning, gravity, what we call gravity-assisted approaches. And with good neuroanesthetic techniques, the brain can become a little smaller and can fall out of the way. And that, particularly for tumors of the base of the skull, that's extremely helpful.
Okay, hold on. Neuroanesthetic
Anesthesia.
techniques make the brain smaller? Seriously?
A little bit.
Tell me about that. Like, how much smaller?
Like this small? No. No.
A golf ball? No.
Like a walnut.
No, this is fascinating.
Well, so so if you hyperventilate, that causes what's called vasoconstriction, and that causes the brain to get a little smaller.
If you hyperventilate?
If you hyperventilate, you blow off,
Okay.
a lot of CO2, you will vasoconstrict. So that's one thing we can do. The other thing is a drug called mannitol, which is a diuretic, and that just releases some of the free water in the body, and it makes the brain, by virtue of that, a little bit smaller. And then positioning, and actually there's a skull up there on my desk. I could, if you want to hand me that, I'll show you. When we position a patient in a certain way, like you can imagine, if you're like this, and we'll
have to narrate this. Now you've just taken the top off this skull for our visitors who are listening only to this. You've just taken the top off of a skull.
And if you have your head straight up and down, to get under the base of the skull is going to be a challenge. But by basically positioning the patient in a certain way and positioning the head back, it allows the brain to fall away, and we can do that
into the back of the head.
Yeah, it just allows it to fall away a little bit from the base of the skull.
Okay.
And those, it doesn't sound like much, but even a little bit of movement and positioning can be extremely helpful to give us more room to work. And so all of these things in aggregate, the anesthesia techniques, the positioning, low profile instrumentation, and then the endoscope allows us to get into these places with smaller approaches and less manipulation of the brain, no need for retractors.
Retractors, that means literally pulling the brain out of the way?
Like literally taking like a spatula and people still use these all the time. I mean, there's a lot of articles about retraction injury, and this is some of the
because
things.
Somebody's using a spatula to move your brain out of the way to get to something.
Yes.
That doesn't sound good.
No, it's not good.
Okay.
So we have now in this sort of portfolio of recent publications, we have 3 articles. One is comparing the removal of a certain location of meningioma that is associated with vision loss, usually more common in women, either doing it through the nose or doing it through the eyebrow. And we wrote an article about that many years ago, and this was a follow-up using this fully endoscopic approach through the nose. And what's interesting, when we wrote the article years ago, we were doing more through the eyebrow and less through the nose. But with the endoscopic approach, we now are doing, the ratio is flipped. We're doing about 60% through the nose and 40% through the eyebrow. And the reason is because this particular meningioma likes to grow out into the optic canals, and it's associated with vision loss. And our best ability to take tumor away from the optic canals and the optic nerves is through the nose, because we have a 180-degree access to the 2 optic nerves coming from below. If you come from above...
between them.
Yeah, you come literally between them.
Okay.
If you think of the optic chiasm...
Which is what?
Is where the nerves cross.
Oh, okay.
So you have a right and a left optic nerve. They're almost at right angles to each other as they come out into the orbits. And so where they meet is the chiasm. So that whole area, the chiasm and the optic nerves, can get stretched by these tumors. And the best, safest way to take these meningiomas away is through the nose, because the nerves are on the other side. So we reach the tumor and the canal before we have to manipulate the nerves. So again...
So you're coming at it from...
Yeah.
Angle
and other people have had similar experience. We're not the only ones doing this, but the bottom line is that the visual outcomes are better with the endoscopic endonasal approach than with the transcranial approach. But the transcranial approach, most people are still doing these big approaches, and we're doing it through a keyhole eyebrow approach.
Okay, when you say eyebrow, do you mean you're not going under the eyebrow? Are you making a hole above or in?
Yeah,
or
so we
along the eyebrow?
So the incision is right in the thickness of the eyebrow, and goes out just past the termination, and the bony opening is about that big. So it's about about 2.5 by 2 centimeters, And so it's a little opening. It's right on the base of the skull. So when we take the bone out and we have you positioned with your head back, the frontal lobe falls away. We sneak under the frontal lobe, and we come on to the tumor. So that's the beauty of that approach, as opposed to doing a much longer incision, like 2 times or 3 times as long behind the hairline, like you or I that have a receding hairline, way back here. But that's really what people do, because they don't want to put it on the forehead, so they go behind your hairline
for
a standard
aesthetic purposes.
Yeah, for a standard,
okay.
And it heals okay. But I mean, it's like, and then they take this much, bone off. So we did this paper. This was published in what's called Operative Neurosurgery. That was published comparing these 2 approaches. I don't want to get into too many details. Then we, prior to that, we did a paper on our entire supraorbital experience. All of the patients we've done an eyebrow approach on.
That's
over 200
above the eye.
The eyebrow, yeah.
Okay, that's
like
right.
Over 200 patients with that approach for meningiomas, malignant tumors like gliomas and brain metastases, and the whole spectrum of tumors. Then we have a paper that's coming out in Journal of Neurosurgery, which is really a nice paper comparing the eyebrow versus what's called the mini pterional, which is coming from the side.
Oh, your temple. You're pointing to your temple here, and
this is 2 approaches to brain tumors, and comparing them. We actually did a really nice thing with our Garni, I'm sure, talked about the anatomy lab.
Yeah,
and
Dr. Barkadarian.
Josh Emerson, Dr. Barkadarian.
Yeah.
Josh Emerson runs our anatomy lab, and he's an artist, and we have a bunch of his artwork in many of our papers. And we did heat maps, which I've never seen anyone do before. We did heat maps of where all the tumors located for the supraorbital approach versus the mini pterional approach, so that surgeons can see the overlap and the separation. And then we showed...
Wait, say that. So the heat map does what?
So a heat map of where the tumor was located on the MRI. So when we look at an MRI and we say, okay, there's a tumor sitting underneath the frontal lobe, and should we do this through the nose? Should we do it through the eyebrow? Should we do it through a mini pterional approach? We have 3 options.
You had 3 ways in.
Yeah. So what we did in this paper is we took all of our supraorbital approaches and all of our mini pterional approaches, and we looked at all the MRIs, and we said, this is when we use this approach, this is when we use this approach. And the way we visualize the data is with heat maps. So we took the maximal diameter of each tumor on an MRI slice, and we drew it onto a idealized skull. I'll show you the pictures.
Okay, and so what that does is shows you...
You know what a heat map looks like? If you look like an athletic event where the players are running around,
Yeah, and it shows where people have been most commonly.
Yes,
this,
exactly.
And it glows where they've been most commonly.
Yes, yes. And so...
Okay, so...
It's a very visual way of looking at the data, of saying, this region is really where you would use the supraorbital approach. This is where you'd use the mini pterional approach. And what was interesting is we looked at the data, and we were, when you write an article like this, you have to go back and see, what's been published on this before and what have people said. Interestingly, the anatomical papers, not the clinical papers, so people who would go in the lab and they do these 2 approaches, they would say, well, the mini pterional approach really gives you more exposure.
To going through the temple here.
Yeah, it gives you more exposure than the supraorbital.
More exposure, you mean more room to see?
More, yeah. So, but our experience was 4 to 1. We used the supraorbital over the mini pterional.
So you're going in over the eyebrow?
Way more. It's a much more versatile approach. And the reason why that is because we use the endoscope on most of our cases, And
Describe the endoscope quickly.
so the endoscope is a surgical telescope, and it's high definition.
And it bends?
No, it doesn't
Does
bend.
not
It's
bend.
rigid.
It's straight.
It's a rigid, high definition scope, 4 millimeters. We do everything we do through the nose. We only use an endoscope. We don't use an operating microscope. Okay, the operating microscope is a big piece of equipment in the room on a big pedestal that moves with, and you aim it into the head, right?
Does it have an attachment? It's got to have an attachment that goes in.
No, it doesn't
No.
go in. The head's here and the microscope is here, and it's
Wow.
shining the light and it's magnifying what
Just
you're doing.
through
Yeah.
the okay.
Through the opening. Yeah.
Okay, so the endoscope though is inside.
The endoscope goes
Got it.
inside. That's the beauty of the endoscope.
Okay.
All of the keyhole craniotomies that we do are generally endoscope assisted, meaning we start with a microscope. So the way we do a craniotomy, let's say we're doing an eyebrow craniotomy, okay? When we start, we're wearing loupes, which are these
Yeah, like
magnifying
what
glasses.
a jeweler uses.
Yeah. So we start with our loupes, make the incision,
Cut through the skull.
open the bone, and then we'll usually open the dura. Once we have
The
the
lining.
dura open, we open the dura. Then we take our loupes off and we sit down at the microscope. The microscope rolls in, and we have a very comfortable chair with armrests, and we have an assistant. If I'm assisting or I'm operating, I'm sitting, and the assistant stands, and that's all done under the microscope. We go as far as we can with the microscope, and then there may be some blind spots because the issue with the microscope is it's great high definition, brilliant illumination. But as you get further in, you start to lose light and you can't see around the corners.
Right.
So then we'll swing the microscope out and we bring the endoscope in. And then we
Okay.
can bring the endoscope in. And so for example, in the supraorbital paper, I think we use the endoscope in about close to 60% of the cases. And it allowed us to remove additional tumor in a majority of those.
And
Or-
that's
That's
what
the
you're
key.
after, right?
Yeah.
Is getting
Or it gives you a view that says, you know what? There's some tumor there, but it's so stuck to this nerve or this vessel, it's not safe to remove it. And so it gives you this additional information that you don't get with the microscope.
Okay.
So that's why all of these keyhole approaches are endoscope assisted. And that's something that is somewhat unique at P&I that not a lot of places do.
I just learned how relatively uncommon keyhole surgery is.
Yes.
Is that correct? I mean, what's the percentage roughly?
I mean, it's all we do here,
Right.
but it's not very common. And I want to tell you about these other papers because
Please.
it's very relevant as we get into this last paper that just literally came out today.
Okay.
So anyway, so we had the meningioma paper we call it from above and below. We do more from below now because it's better for vision. We talked about our supraorbital approach, the big experience of that. And then we did this comparison approach of the mini terional versus the supraorbital. And we find the supraorbital is much more versatile. Part of the reason it's more versatile is because with the supraorbital approach, you can also get to the other side. Coming from the temple, you can't get from the right temple, you can't get to the left side at all.
Mm-mm.
But from the eyebrow, you can actually go across the midline. And a lot of our tumors that we remove through the eyebrow, they had an extension to the other side. So that's part of why it's used so much more commonly than the mini terional.
That's why it's used so much more commonly by
us.
by you.
But I think people, when we looked at some of the literature on this, in fact, the supraorbital is used more than the mini
Okay.
terional.
Were you surprised by this? Or did it just illuminate sort of what you're...
Well, I was a little surprised, but not that surprised, just
Okay.
because it's such a versatile approach. Now, partly it is you get very comfortable with what you can get away with through a small opening through
Sure.
this particular approach. So some of that is the learning curve. But I think this will be an important paper that people will learn a lot from. So that's those. Then, then we had a paper that came out, our 10-year experience of endoscopic endonasal pituitary adenoma surgery, just for pituitary adenomas.
Okay, so wait, give me that in layman's terms.
Yeah, so removing pituitary tumors through the nose with an endoscope.
Okay.
And this was something we started about 10 years ago. Others started before us. We were doing endoscope assisted through the nose, but our pure endoscopic series really started in 2010. So we looked at all those patients, 514 patients.
That's a lot.
It was mostly Dr. Griffiths and I.
Right, because
And-
you work together.
Right?
Because
He's
he
the
handles
ENT.
getting you to the pituitary, right? And
Yep.
then you do
Yep.
the tumor removal
Right.
around the pituitary, which is the size of what, your thumbnail or your...
Yeah, it's about the size of the thumbnail, but sometimes these tumors can be, 10 times that in volume. They can
Are
be.
you serious?
Oh, yeah.
Of the pituitary?
Oh, yeah, sure. They can be egg-sized.
Are you serious?
Yeah, they're
In
called
that tiny
giant
space?
adenomas. Is anything over 4 centimeters in maximal diameter. So we have, in that series, we have a number of giant adenomas. But,
Oh my gosh.
a 2 centimeter, 3 centimeter, those are common. We operate on two on Tuesday. Both were, 2.5
And
centimeters.
that must compress all sorts of things
Yeah, well,
around
that's
it,
why-
right? And the pituitary stops
That's why we
functioning.
operate on them.
Yeah.
Yeah.
And just so everybody knows, the pituitary is a very important gland.
So the
right?
pituitary gland is the master
master
gland,
gland.
controls all your hormones, and pituitary adenomas are the third most common primary brain tumor after
Are they
meningiomas.
malignant or...
They're almost all benign,
Okay.
which is good.
Yeah.
They grow slowly, but they cause either loss of pituitary gland function or hyperpituitary function, like acromegaly, too much growth hormone, Cushing's disease, too much cortisol, or prolactinomas, which make too much prolactin. And in women, that causes their menstrual periods to stop. In men, it causes their libido to go down, and your testosterone level goes
Wow.
down. So you can have a secreting tumor like that also is causing the other issues of a big tumor, causing the gland to fail, cause vision loss or headaches, and they can hemorrhage. They can also bleed, which is called pituitary apoplexy. So there's multiple reasons we operate on them. But as I said in that paper where we looked at the elderly,
coming back to the paper.
on that other paper,
Yeah.
we about a quarter of the ones in the elderly we didn't operate on. So in this paper, we summarize, basically it was a focus on complication avoidance techniques, which we are known for. So using the Doppler probe to localize the carotid arteries.
Tell us about that. That you're using the sound of the blood, aren't you? Are you
Yeah.
correct?
So if you think of the pituitary gland sitting in the middle of the skull base, the two carotid arteries come up and they wrap around the pituitary gland. They're like the goalposts. And if you think of the goal as, in the middle, the two carotids come up and they basically hug the pituitary gland before they go up into the head.
And these are
irrigate your
pretty
brain.
important
These are-
goalposts.
Yeah,
Just
they're
FYI,
life-giving goalposts. And,
because all the blood
yeah.
that's pumping into your brain.
And one of the most catastrophic complications of any endonasal transphenoidal pituitary surgery is a carotid artery injury.
Meaning
That you injure the vessel. You put
nick it,
a
you
blade
put a hole
into
in
it,
it.
or you grab it. Yeah, you didn't
okay.
see it,
and then what?
and then it's a
Blood everywhere.
blood everywhere like you've never seen jetting out the nose. It's a really
Oh my gosh,
harrowing.
really?
It can be a harrowing experience. Yes. So in this paper, we had 0 carotid artery injuries, none. And the reason is
Out
because
of 500 and
514 cases. But I have had a carotid artery injury. I've had I think 3 or so over the years, way back when. And I learned early on, this was like in 1998, 99, I had a carotid artery injury. I had 2. Fortunately, both patients lived, did okay. But after those, we started using the Doppler probe on every single case. And we published about this in 2006 or 7 on the use of the Doppler to avoid carotid artery injury.
the Doppler tells you
So the Doppler
about
is
the more exact location.
Yeah, think of the Doppler as a sort of a little bendable pencil with a long, thinner than that. And you lay it on the bone or the soft tissue. And if you're on the vessel, you hear this, and it's very directional. You can move it. It's very sensitive. They're great.
And again,
probes.
this is in someone's head.
So we put this. So
Yeah.
we've done Dr. Griffiths has done
Opened it up.
He's opened it up, done the approach. We've started to remove the bone, and we know where the carotids are. We know where they should be, but they can be hard to see because they're behind tissue and bone, and sometimes also the bone is actually missing. People have a thinned bone in the back of the skull base for whatever reason. And we have videos. I mean, actually, we were part of a multi-group publication of many carotid artery injuries because this is such an important issue. A group of us got together and published everyone's carotid artery injuries together of, what are the common threads and what are the, and people have shared videos. I give talks on this. I have people's videos of their carotid artery injuries. And for example,
Are these on YouTube?
they are not. Well, they might be. But the point is that you can really get yourself into trouble. And so the Doppler is literally a lifesaver of avoiding those kinds of injuries because we never open the dura before we've listened with the Doppler. So we'll use navigation, we'll use our GPS probe, but that's based on the MRI and the CAT scan done before the surgery.
GPS probe, literally, not
literally.
global positioning.
Yeah, no, well,
What?
I mean, we call it. When I explain it to patients, I say it's like GPS. So we have a probe. So based on your MRI and your preoperative CAT scan, we have a probe that will, if I put it on the tip of your nose, it'll say, we're on the tip of your nose. If we put it,
Seriously?
right where yeah. Oh yeah, we use this in every single case. We use navigation on every brain tumor case. So
So
the
how many things
navigation
do you have in your nose at this point? I mean, is it one at a time? The GPS probe, the
so
Doppler probe?
we have three things in the nose when we're doing the operation. So you have the endoscope, because you got to see, right?
Got to see.
So it's usually in the right nostril. And then we have an instrument in each nostril. So if Dr. Griffiths is driving the endoscope, he's got the endoscope parked in the sphenoid sinus, and I've got instruments going in, or Dr. Barkadarian, and we have our instruments working. So the camera is parked in this room of the sphenoid sinus showing us.
This room that's how big?
It's not very big. It's
Like the
2
golf balls?
2 by 3 centimeters.
Okay,
it
all right.
depends on the approach.
Does
how
that
big
feel
it is.
luxurious to you, or is that?
It does.
Yeah.
But again, the room is, the nuances of how much bone do you remove? How do you move the mucosa out of the way? How do you, all these things. So, at any rate, the paper. Let me go back to
Please.
the punchline of the paper is we highlighted 4 complication avoidance techniques that include localizing the carotid arteries, something called rescue flaps. This relates directly to what Dr. Griffiths does, and our colleague Dr. Corral, who was here with us, of basically, if you have an operation but you wake up and you never smell again, that's not a good thing, right?
No.
So one of the things that we've gotten very good at with our ENT colleagues, and this is the part of the point of the paper, is this collaboration between ENT and neurosurgery has totally transformed endoscopic
Well, that's why you have
surgery.
ENTs here, right?
Yeah,
I mean,
that's why they're part of the Neuro
Yeah, it's-
Institute. Yes,
you're
So-
after the same pieces of real estate there, and okay.
right. So, so one of the big parts of the paper too is this technique where we preserve the mucosa that's related to olfaction, so that we don't have people that lose their sense of smell. I mean, our rate of anosmia, where you lose your sense of smell, was like 0. We had some hyposmia, but we had no one completely lose their sense of smell.
Because
And
because the risk is that you damage the mucosa by going through it.
Well, or you go too high where the olfactory fibers come down from the brain side of things. And so this technique basically preserves the mucosa. It pushes the mucosa out of the way, sort of like drapes. And we don't resect as much, and we don't remove a lot of the things called the turbinates. There's all these structures in your nose that a lot of surgeons and surgical teams just remove to get back there.
Seriously.
So we have a very green approach. We don't remove mucosa, we push it out of the way, and we're very respectful of the natural structures, and we save them. And so that was one component is the ability to prevent loss of sense of smell, carotid artery injury, gland injury. We have a very specific approach to how we handle the pituitary gland, so that our rate of gland loss is around 4 to 5%, which is very
Gland
low.
loss.
Meaning, like, you have an operation on your pituitary gland, and now you have to take thyroid, or now you have to take cortisol replacement. The risk of that, and 95% of our patients don't have that. But the bigger the tumor gets, the more at risk the gland is.
Sure.
But those are very good numbers. So 5% is really good. And then the last thing is spinal fluid leak and meningitis. So because we're operating in that, a lot of the tumors get up into the space where we get a spinal fluid leak, where the spinal fluid flows around the brain. We have to repair that, and we've had a repair protocol in place for many years, and we published another paper about that not too long ago. And our leak rate is around 1%, so really, really low leak rates, and meningitis rate of less than 1%. So the focus of the paper, and then we talked about our removal rates, the resection rates, and all that.
But the rates of
how
much?
how often did we cure patients, 60%, 70%, 80% of the time. And so some tumors are more invasive. Some tumors are out around the carotid artery. You can't get them all out. And so we had very good resection rates, but the focus of the paper was complication avoidance techniques.
Yeah.
So it's 514 patients. All of the major complications were under 1%. 98% of the patients were discharged to home. The median length of stay was 2 days, and now most of our patients go home in 1 day. So
staying overnight, or
they stay overnight. So they have surgery and then they go home the next day.
They have brain surgery. They stay overnight and they go home.
They go home the next day. Yeah. So that was that paper.
That's impressive. Were you?
Yeah.
Did those numbers surprise you, or did you have a hunch that?
No, we knew they were.
But now it's
we
in
knew
black
they
and
were
white.
good, but we wanted to get it out there. It's
yeah.
a nice 10-year series. It's one of the biggest in the literature, and again, we're a little community hospital, and this is a big paper.
Where was that published?
In Pituitary, of all places.
So that's the
journal,
industry standard
called,
for.
Yeah, it's called Pituitary.
Okay.
And so it's a nice paper.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation.
So then, the last paper I want to talk about that literally just came out today.
Good timing for us here.
It's so timely. It's called Streamlining Brain Tumor Surgery Care During the COVID Pandemic.
Ooh.
And basically what we looked at was we looked at, we knew that so the pandemic hit, and we still have patients showing up with brain tumors and pituitary tumors. We got to take care of them, but the hospital's getting full with COVID patients. Patients are afraid to come in. What do we do? So we already have this foundational approach of minimally invasive surgery, getting people out of the hospital early, all these things, complication avoidance techniques. But we knew we needed to go a little bit further. So we started preparing patients more. We see them here in the clinic, and we say, look, we're in the middle of a pandemic. You don't want to be in the hospital. We need the beds. If you're doing good, you're not going to go to the ICU, and we're going to boot you out of here on day one. Provided everything's good.
Sure.
So we started doing that, and we kind of formalized it, and we also brought in, the nursing team, like Amy Eisenberg, who's our amazing nurse practitioner, who you should do a podcast with.
Bring it on. It'd be great.
Amy's fantastic. And with administration and with the ICU team. And we basically, we said, okay, we have to do better. We cannot not take care of these patients, but we have to be working within the pandemic here. We gotta, at one point for this little hospital, we had over 90 patients. We were out of ICU beds. In the December, January. I mean, we were maxed out. It was terrible. So, And we already do almost all of our patients get a CAT scan right after surgery. So they leave the operating room, they go to recovery, they get a CAT scan.
What are you
make
looking
sure-
for there?
We just make sure there's no
everything's-
bleeding, making sure, like, if we do a reconstruction and when we repair the skull base for spinal fluid leak, make sure everything looks good. But that gives you a sense of confidence that the patients, if they're waking up well and their scan looks good, you go, well, this is great. You know, you could even go home now. You know,
Right.
you can. But-
Unbelievably, right?
So, so basically, what we did in this paper is we went back and I thought, you know, we got to look at this. No one's published anything about this. You know, this would really, let's see if we really move the needle. So we went and we looked at 2 11-month periods. We looked right up to before the pandemic. So 2019, I can't remember the exact dates. It was like March through February.
2020.
And then we looked
right before it started.
Then we looked at April through March, another 11-month epic. So we
you
looked
get
at
control and
we looked at 2 exact periods, pre-pandemic, pandemic, and we looked at all the demographics. You know, was the patient population? We looked at all brain tumors. So anything through the nose. We broke it up into an endonasal cohort and a craniotomy cohort. And we had just under 300 patients, and we had like 317 operations because some people ended up getting a second operation. And we had, you know, a little bit more in the pre-pandemic period because we were a little bit slower
Sure.
during the pandemic. And basically, our use of the ICU went way down. In the craniotomy cohort, it went down from 80% to 30% approximately. Our discharge on day 1 went up from 12% to 40%.
is day 1 the day of surgery or the day after?
It's the day after surgery.
Okay.
Day 0 is
Got it. Okay.
So basically, we shifted the curve. We had many fewer patients going to the ICU, which is great for the ICU team.
So they must have
And
loved
we
you.
had most patients going home on day 1. And then we looked at how sick were the patients. We looked at complications, readmissions, reoperations. So, you know, like if we're doing all this thing really quickly now, are we just creating more trouble for ourselves? And we didn't at all. Everything stayed the same. The rate of tumor resection was the same. The complication rates were the same, very low. Readmissions were the same. And reoperations were the same. So basically, we shifted the curve dramatically because of the pandemic. And, you know, we use this, I put this actually in the discussion of the paper, you know, as Winston Churchill said, never let a good crisis, you know,
I was going to say.
go unaddressed, you know, and we took advantage of it. You know, we had this sort of foundational concept of minimally invasive surgery and complication avoidance. And then we layered on this a more intensive protocol of patient education, patient assessment in the recovery room, and just getting the team ready and then checking on the patients when we would send them home early. You know, it paid off. And you know, we're going to obviously continue doing that. And actually, toward the very end, we actually, working with a post-op surgery place to send patients home the day of surgery to spend a night at a little outpatient convalescent place where they could be near the hospital. We did that in a few patients, and we haven't done more of that, but it does show proof of concept that we could be sending a lot of our patients home the day of surgery. They could have same day brain tumor
That's
surgery.
amazing. So this is big time silver lining from the COVID epidemic.
Yeah, and
Because you're going to continue.
we're
with
going to
these
continue
practices.
doing that. Yeah, and this was published in a journal called PLOS ONE,
Yep.
and literally just out today. I'll send you the link. But we're really, you know, proud of it because it's a unique experience. It was a sort of the cauldron of the pandemic helped us do this, but the pandemic was really sort of an accelerant on these other things that we were already doing, and you know, it was good for the hospital, good for administration, we think there's actually some big cost savings that
That crossed my mind. There's got to be,
the
right?
CFO and the COO are interested in looking at they're gonna look at the numbers, because you're just not using as many resources, and
No. And that's the big cost, isn't it? Is
mhm.
ORs and intensive care.
Yeah, the
it's
ICU and-
monstrous, isn't it?
Yeah, it's very
Yeah.
expensive. So those are the papers that we have now, and we have a paper that's going to be submitted very soon on our whole meningioma experience. Going back to meningiomas, the whole keyhole experience, and that's a hopefully that will be published in the next few months.
You're making us look bad here. You got a lot done during the pandemic.
We were busy.
I'm starting to feel kind of lazy. Everybody else is holed up watching Netflix. But it sounds like you made some real progress.
We did take
you sort of
advantage.
had to keep.
Yeah, we took advantage of the downtime. I mean, I've been wanting to do all these. We've been doing papers, for years. We're always pumping out the papers, but these are some big series that we did that I've been wanting to do. Actually, the other paper that is will be published, is we just sent our revision in, is on Cushing's disease, a la Sharman McGraw,
Who we interviewed earlier.
Who you interviewed.
Yeah.
Sharman was one of my early Cushing's patients 20
Describe
plus years
Cushing's
ago.
for us, would you please? That's just.
Cushing's disease is when the pituitary gland has a group of cells, the normal cells that are called corticotrophs, that make adrenocorticotropic hormone. That hormone causes the adrenal glands to make cortisol. That's the stress hormone. Can't live without it. But if you have too much, it causes weight gain, hypertension, diabetes, increased infections. Women often lose their periods, neuropsychological issues, osteoporosis. Terrible.
This is the fight or flight.
Yeah.
Kind of get your body ready.
Yeah. And if you've ever seen anyone who's been on prednisone for too long or on another steroid like dexamethasone, they start to balloon out. They get this round red face.
Why does that happen?
Well, it's the fat stores it starts to deposit fat, and it also wastes your muscles away too. So you get a myopathy, you get a muscle wasting, and you get weak legs.
Do those patients also get mania?
Yeah,
Do they
can
because you're on basically you're on a your body's steroid.
Yeah, absolutely. They have a lot of neuropsych issues. They're not, and they get brain atrophy. And my mentor Ed Laws has published on this, looking at brain MRIs of patients with Cushing's disease. Their brains are shrunken,
Literally shrunken,
relative to a normal age-matched group. Yeah.
Why does that happen? Is that just
That's a good question. I don't know if we know why, but it is an effect of obviously too much cortisol going into the brain. But that's why it's such a debilitating disease. So,
oh my gosh, yeah. So the paper.
So the paper is looking at 106 patients, again over many years, since 2008, I believe, our whole series. And one of the biggest issues with Cushing's is, do you have Cushing's or not? So there's a lot of people who are running around who are hypertensive, obese, and diabetic, for example. And a lot of them, when they hear about Cushing's, they go, I have Cushing's. I want to have that. And there's some very set biochemical testing that we do. You have to test the blood, the saliva, the urine. There's ways to measure cortisol production and ACTH. It's very sophisticated, one of the most complex areas of endocrinology. And it is really one of the most difficult diseases to diagnose sometimes and to misdiagnose. So in this paper, we looked at the diagnostic pitfalls because we have had a subset of patients, Dr. Barkadarian and I and our endocrine colleagues, Dr. Cohan, who we weren't entirely sure that they had Cushing's, but we didn't know, we couldn't prove that they didn't, and these people were dead, and we would operate on them. And we would not find a tumor, and their levels would not go down, and we never know what they had.
Interesting.
And there's every pituitary surgeon I ever met in the country and the world have had these patients, and no one's really kind of written about it, of this, what I call not Cushing's. You've got something, I don't know what you've got, you look the part, but you don't have Cushing's as far as we can tell. And the problem with Cushing's is that the tumors are usually very small. Unlike, a lot of the non-functional tumors, they're big. They're easy to see, they're big, and they're causing a problem.
Non-functional meaning
They're not making a hormone. They're not hormone
because
producing.
tumors can make a hormone.
Yeah, so
they cannot.
If you have Cushing's, you're making too much ACTH.
Because the tumor's making it.
Yeah.
Okay.
If you have acromegaly, you're making too much growth hormone.
Because the tumor doesn't know when to shut off and stop making this stuff like the pituitary does.
Yeah. So the ideal Cushing's patient is they have high urinary cortisols, they have high ACTH, blood cortisols, their salivary cortisols at midnight are very high, abnormally high. Their diurnal rhythm is all off. And on their MRI, they have a well-defined little adenoma.
This is like the down the middle.
This is like the perfect.
We got
case.
this.
Yeah, I just saw a patient in follow-up yesterday. It's the perfect little
You're like, we can fix this.
4 millimeter tumor that we'd operated on a few months ago. She's in remission. It's great.
Fantastic.
She's doing great. Then there's this, but about a quarter of our Cushing's patients with a high resolution pituitary MRI, there's no tumor seen. You can't see it, so you have to literally explore the gland with a bunch of cuts. And
when you're in there.
Yeah, we literally sliced up like a loaf of bread. So, so the diagnosis is based on the biochemical data, not on the MRI, because the MRI doesn't matter. If they fit all the criteria and you can't see it on the MRI, you know it's there. You just have to find it. Okay. So, but we went back and we looked at this 106 patients, and we knew there was a subset. It turns out there was 15 of them in which we said, you know what? Their cortisol levels didn't drop. We didn't find a tumor. The pathology didn't show a tumor. They never got better. This is a special group of patients. So we looked at them separately from the other group, and we found marked differences in their biochemical data. And it's never been published before. And so this paper is going to be published in the Journal of Clinical Endocrinology and Metabolism. It's a really good endocrine journal.
Yeah, sure.
And we have a collaborator from NIH, Lynette Neiman, who's the world's expert in Cushing. She's on the paper, and it's going to be a really nice paper.
So what was going on with this group over here?
The group of 15?
Yeah.
We're still trying to figure that out. In the discussion of the paper, we say, this is an area where we really need to understand what they have. We know they have something. They're not right. They're metabolically not right. But as far as we can tell, they don't have Cushing's. Fortunately, we didn't hurt any of them. We operated on them, and some of them went on to get the sort of end-all be-all cure for Cushing's is to remove your adrenal glands, because that's where the cortisol is produced. So actually 2 of the patients, or 3, had their adrenals removed eventually.
Is that sort of a last resort?
It's
because
a complete
you need
last
adrenal
resort. Yeah, because then you have to be on some other hormone replacement and all that.
Right.
So anyway, that's the other really nice paper that's coming out.
And that group's the not Cushing's group.
Mm-hmm.
Okay.
The remission rate for the Cushing's group is 84%. It was very high.
Okay.
And the ones that didn't go into remission were because maybe the tumor was invaded around the carotid artery and some of these areas where you can't get to it.
Yeah, so you're leaving some of that.
But the remission rate's very high. So if they meet all the biochemical criteria, you should have a greater than 85% chance of curing them with surgery.
That's a gratifying number.
Yeah, it's a good number.
So that's an impressive list of papers. Yeah. You got to be thrilled with some of those results.
We're pretty happy.
Yeah. Do you do the writing on these?
I do a ton of the writing. I'm the senior author on all those papers, and the writing is mostly our fellows and our students will start them, and then I'm a relentless editor. And my mother was an English teacher.
That'll help.
And I'm pretty particular. And conceptually I design them, but we've had a couple fellows recently, Dr. Thacker and Dr. Avery, who are very sharp guys, and they had a lot of good ideas, and they're really good. Jay Thacker is a really good statistician, and so it's a really collaborative process. And Garni Barkadarian helps me a lot, and he's a surgeon on all these papers. He's my partner, and of course Dr. Griffiths is the ENT, but the real guts of the process of writing the papers is the fellow and
Revision.
me and
Yeah.
the students, and we have an amazing group of students now have been helping us
Students.
that are applying to medical school, that sort of thing, postgraduate, that are here working with us doing
Oh, that's fantastic.
yeah, we have a number of them, a bunch of them that have been helping us. And R.J. Malari, he's the one he's actually the first author on a number of these papers. He's been amazing, and he's going to spend another.
And where is he in his career?
Well, he's graduated from college, and he's applying for medical school. We're going to get him into medical school.
What a great experience for him.
Yeah, so it's a really good educational process.
So what is the status of keyhole surgery? I was surprised to hear it from someone else that it's still low. Like you are doing this with great results. Is it beginning to spread, or?
I think it is, but I think a lot of places are still afraid of these smaller approaches, and you can even see it in some of the commentary we get on the critiques of our manuscript. So when you send a manuscript in, if you'll either get a rejection or you'll ask for a revision. They always have something they want you to address, and
Because editors need to be editors.
right, and they send it out to experts in the field.
Sure.
I review a lot of manuscripts, and and you try to be constructive, and or if it's not novel, you may reject it, or if it's really poorly written, or the data analysis was bad. There's all reasons.
Do you see poorly written papers?
Yes, I
Yeah.
mean I would say, but I see a lot of really good papers, and actually the editorial process usually makes them better. There
Sure,
is a
I
method.
hope so,
There's
yeah.
a method to the madness.
Mm-hmm.
So it can be frustrating, and you can read some of and sometimes you can you're always kind of go, I wonder who said that, because they're anonymous. You never know.
Oh, the comments are anonymous.
Of course, yeah, and you can see who's on the editorial board. You might, but
You can
it
guess.
doesn't matter. You gotta trust that people are being objective and
Sure.
reasonable, but I remember in the superorbital versus the mini pterional paper, one of the comments was something about how the eyebrow approach is so prone to infection and bad cosmesis, and
Cosmesis
meaning the how does it look
afterward.
and I just laugh, because in our paper on the supraorbital approach that we just published, I mean, we have a montage of like 10 patients. I mean, most of them
Pictures.
you can't even see.
Well, I was going to say, that's
can't
easily
even-
addressed.
You
How about
can't
some
even,
photos?
You can't even see where the incision is. I mean, we put in one picture of a patient who didn't have a great outcome way back when, but and they're not all perfect. But most patients are so happy with the cosmesis and the way their eyebrows move and everything.
Because there's
and-
muscles there.
Yeah, I
People
mean,
forget
and then
that.
we always tell them that you're going to look like you had a Botox injection. You're going to be numb for at least a few weeks or
Well,
even
that's
a few
true
months.
for
I mean,
my daughter just had knee surgery,
Yeah.
and she can't feel one side of her kneecap.
But I think we had one infection out of 200 cases, so that's a 0.5%. And
Yeah.
I just said, to the reviewer, when you address these things, you have to be kind of calm and measured. You said, well, obviously, there is a misperception. Please look at this article and the photograph, and look at our infection rate. There basically are no infections. So this, and I said it would be truly sad if in fact Many surgeons, neurosurgeons, are shying away from this because they're afraid of the healing and the infection issues. I said this is why we're writing these papers, to educate people that these are perfectly safe and they're better. I mean, the idea is, do you think your body tolerates an incision this long, or you want one this long?
Well, that's what I was going to say.
Do you want to
They're
open the
comparing
bone?
it
Yeah.
to
Do you want to open the bone, 2 by 2 centimeters, or 6 by 3 centimeters? What do you want? How much tissue do you want to disrupt?
yeah.
So, that's it. It's a surprisingly hard sell, but I think all of these papers coming
is this just hidebound habit?
Yeah, a lot of that's what it is.
and-
It's people clinging to their ways and not adapting. But there is a group of us out there, and I have some great colleagues around the country and around the world who embrace this fully, and we're constantly pushing this, and it's getting out there. It's slowly happening, but like our fellows. I mean, we've had now 12 or 13 fellows. They're all out there doing this. They're out there in the world doing these cases, and this is part of the reason I'm having a fellowship training program, and sharing this approach. It's better for the patients.
Sure.
It's better for the hospital. And this COVID paper shows how you can, people do not need to be in the hospital for 3 days after craniotomy. They can,
I mean, getting out, the less time in the hospital is better, right?
Yeah.
I mean,
get the heck out.
Get out. Yeah.
Go home with
and
your
get up
family.
and start moving, right?
Right.
We were talking to one of your colleagues
Yeah.
about how getting up and out has all these benefits.
Yeah.
Taking
Absolutely.
pressure off the head from not laying down, I think she was saying.
Yeah.
Just things like that.
Right. So it is a slow transformation, but this portfolio of papers, I think, is sort of nicely summarizes more than a decade of work of stuff that we've been doing in this area, and we have really some of the best results that are out there, and
It certainly sounds like
it's very honest. We're very hard on ourselves. We show all our complications. We show all the bad stuff, and and that's really important. You got to have truth in advertising, and the data's got to be available. Actually, now the journals require that you put a statement that you're willing to share your data.
Oh, I would hope so. Yeah.
So
Is that new?
it is new. Yeah.
That's a great development.
hmm Yeah, like in this
You
Cushing's
have to show
paper.
your work.
Yeah, like if you want to, it has to be a reasonable request. Someone says, can we see your Excel file of all your, and we'll share it.
Yeah. Well, I know from experience talking to all of you that you're open.
Yeah, I mean, my mentor Ed Laws, boy, he was an editor of the journal Neurosurgery for many years. He was a stickler about, just say it, tell it what it is. Just get it out there. You're going to help people. You're going to help other surgeons.
Sure.
Try not to make the same mistakes you did.
Yeah. And how great is that? I mean, minimally invasive is a trend across surgery, isn't it? I mean, I remember 20 years ago, I watched an open prostatectomy where they had to move every one of the guy's organs out of the way. I mean, his stomach, his intestines, his pancreas, I don't know what else, all of it. And there was a gaping hole in his belly to get to the prostate,
Those days are gone.
right? And
Now it's with a robot.
I mean, talk about, did you call it resection?
Yeah, or removal, yeah.
Or no, but what's it called when you move things aside? Sorry.
Oh, retraction.
Retraction. Talk about
Yeah.
retraction.
Yeah.
No, we're talking about giant clamps. Like it looked like
Yeah, I know.
a construction site.
I know.
And now, of course, you've got the And I just had a friend who had his prostate removed last week, and they did it with the Da Vinci
robot.
machine.
Yeah. Yeah.
And he has,
Exactly.
a few little holes,
little
and
punch-
he's walking around.
That's so great.
So this is not just,
No, it's-
okay, you're bringing it to brain surgery, but that's the trend, isn't it?
It is. And I think we put in the COVID paper that this approach is applicable to many other subspecialties.
Sure,
Yeah.
sure. I mean, it makes nothing but sense.
Yeah.
I mean, I imagine it's more challenging for somebody who's used to having this big, broad view and, right, into...
Yeah,
Anatomy.
that's the problem, is that people don't like the restricted view. But that's the beauty of the endoscope, the navigation, the gravity assistance, all these things you just don't need, I don't want a big view. We don't want to expose all that brain. You
You have a saying, don't you? About
sneak in, sneak out.
sneak in, sneak out, but also the more air to the.
Oh,
what is
well,
it?
there's someone wrote a paper, or no, someone wrote a book, I think, called When the Air Hits Your Brain.
And it's just
Well,
bad.
I guess, yeah, it is. It's not so bad actually,
Okay,
but the point is, you just don't need to, and you don't want to see all these structures. You want to be very focused. Just keep it low profile, very focused.
I imagine
keyhole.
that it is. It cannot be easy though, to be in this tiny little hole with all these instruments. I mean, I imagine you get used to it. It must look like.
Yeah.
I imagine to you it looks like this room, but
Yeah, it's where we live.
It's where you live.
But it's a doing. I don't do things the way I was doing them, 12 years ago. I mean, we've gotten better.
Yeah.
But the concept was back there, but we've gotten better and better and better. And the endoscopes have gotten better, and we've gotten more experience. A lot of it is that we have a really experienced team. I mean, like Dr.
we've been
Griffiths
doing these.
and
I mean,
Dr. Barkadarian, Dr. Sivakun, we have a really good team of surgeons.
yeah.
So, yeah.
And these things take more than one, right? I mean,
Yeah. And for the craniotomies, I'm with our fellow. And, so it's always two people.
your fellow is.
Fully trained neurosurgeon doing a year with us. So we don't operate, very rarely do we operate by ourselves.
Right.
Yeah.
And that's, I mean,
And we have an incredible OR team. We have our scrub techs are fantastic. The circulating nurses. We really are blessed with a great group of people in the OR too. That are super helpful, and they just know what we need. So
excellent. Thank you, Dr. Kelly.
thanks, Anthony. Good to see you.
Good to see you.